Yes.
Thank you for your so much a lot of interesting and exciting presentation. So my name is Hưng. I came from Cần Thơ City. Is a city from the south of Vietnam. Yes, from far from away. I want to ask about the first lecture of Professor Awa. Yes. About the spinal metastasis. So when we access the general status of the patient to deciding the intervention for patient, you mentioned about the SIN score. Yes. I want to hear about your personal experience about RF or Seaman augmentation in case of spinal metastasis. When we consider about the stable, but the patient only about intractable kinetic pain. Yes.
So I don't do RF, but I work in a practice that has pain specialists that do RF. And even in the public hospital I work in, the pain service does provide radiofrequency for pain as well. I don't personally send anybody for radiofrequency with pain from cancer pain or spinal pain. I just don't see those kind of patients. The patients that come to me requiring a decision on stabilization or decompression or both. And if there is an issue of pain, my preference is to send them for radiotherapy because that's proven to help with pain. I'm not aware of any evidence for radiofrequency with back pain. I do know, however, that the pain specialists I work with, they do radiofrequency for pain. And they also do something called medial branch blocks, which is very similar to radiofrequency, which does help with the pain. But to what degree that works and how effective it is, I don't have much information, unfortunately. There's no evidence behind that.
Yes, I know. I know about that.
Yes.
But how about the Seaman augmentation for single level?
What complication? Sorry.
Seaman augmentation. I mean vertebroplasty.
Oh, vertebroplasty.
Yes.
Yes. Okay. Yes. So actually, that I do that. I did a lot in the UK. In Australia, we don't do very much because it wasn't part of our coding system. That's now actually changed. So I have done 2, I think, in Australia in the last few years, but I have a vast experience from the UK. In my experience, I know there was a big study that showed it doesn't help with pain for osteoporosis fractures. But in my experience for crush fractures, when it's related to tumor, it tends to work very well. But that's anecdotal. I don't know if there's any evidence behind that. But yes, it does work very well from my small experience for pain with cancer pain in the presence of crush fractures. But you've also got to understand where the pain is coming from. If the pain is not coming from the crush fracture, then clearly your vertebroplasty is probably not going to help much. But yes, there is definitely cases out there of people having vertebroplasties for cancer pain.
Yes, because through the vertebroplasty, we also take the tumor biopsy for pathology. Yes.
Correct. That was what we were doing in the UK. So we used to put a Jamshidi needle in, take the biopsy for the tumor, and then while we were there, we would place a balloon and expand. So this is the kyphoplasty, and then do the vertebroplasty into the void, and that would help with pain.
But you mentioned about the kyphoplasty, but I wonder about the effective of cytotoxic between the kyphoplasty and vertebroplasty. When you injecting a little amount of semen, the kyphoplasty will not distribute the semen around the tumor, and you when you just vertebroplasty, the diffuse of the semen around the vertebral body is better than kyphoplasty?
It depends on the tumor, depends on
Yes.
where the tumor is. It depends on how much extent of spread of the tumor is, how lytic the vertebral body is. Depends on how compressed the vertebral body is. There's so many factors to making that decision. So sometimes we would just put the cement in, straight vertebroplasties,
Yes.
and sometimes we would you put the balloon in and expand, try to restore some anatomical height, and also make some space for the cement. Also, the vertebroplasty is not just about making space for the cement. Sometimes you have to do what's called eggshelling. So if you just put cement into a vertebral body that is lytic, completely lytic,
Yes.
there's a bigger risk that the cement will come out of the vertebral body into the spinal canal or anteriorly into the abdomen around the vessels. Much higher risk of this because there's no vertebral body, it's lytic. What you can do is what we used to do in the UK is something called eggshelling. So that means you put a little bit of cement followed by the balloon and you expand that cement. The cement then creates an eggshell and you wait a while till it hardens and then you fill that void with cement so that cement now does not go outside of the vertebral body. So it depends on there's lots of little tricks, but I understand what you're saying, but it just depends on multiple factors as to which way you do it.
Yeah, thank you. About the second question about you mentioned about the first case of the presentation about Z-score is 10 score. So that means the patient has potential unstable. Yes. I want to hear your opinion about MIS stabilization with or without vertebroplasty. Because according to the presentation, the patient only has intractable pain. Sure.
Yeah. So we don't commonly, like I said, in Australia, we don't commonly do vertebroplasties anymore, but we do MIS stabilizations, and we would commonly do that in a patient with a SIN score of 10, 11. But again, this is about what I mentioned before. You have to take every case as it comes. So when a patient is referred to me from the cancer hospital, I will go and see the patient. If the patient doesn't look very well, if they're cachectic or they what's the word? How can I put this? They don't look like they're in good medical health. Why would I put them through an operation, even if it's MIS? So I may prefer a brace and manage them conservatively. And we will do that a lot. We will say no brace, that's enough for the patient. But in patients where they're quite good, they're quite well, and we want to mobilize them quicker because we're worried about them lying in bed with a chest infection, then yes, we may do MIS screws and get them up and mobilize them quicker. But we do a lot of that. I can't say we do a lot of kyphoplasty currently in Australia. That may change, but at the moment in our practice, we don't do that.
Thank you.
Oh.
May I make the question in Vietnamese? May I make my question in Vietnamese?
We need translator.
Please translate to English for me, please. Em cũng có hai câu hỏi ạ. Vâng, em có hai câu hỏi cho phần
Okay, I have two questions for you.
phần chấn thương cột sống.
About trauma, spine trauma.
Câu hỏi thứ nhất là đó là trong cái bảng phân loại về TLIC ấy, thì ở cái mục đánh giá về dây chằng và thần kinh thì chúng ta không có điểm số 1 mà chỉ có điểm số 0 và điểm số 2. Cái này khác biệt so với cái bảng đánh giá về chấn thương cột sống cổ. Thế liệu các giáo sư có thể giải thích cho em tại sao lại không có điểm số 1 ở trong hai cái phần này được không?
The first question about PLC complex assessment in the TLICs. There's no one point, right? But is it different to the TLIC for cervical trauma? So can you explain for us about why we don't have the 1 point for PLS complex injury we have only 0 point is intact. We have suspect 2 point and we have a clear and injury 3 point. So can you explain about it? Thank you.
That's a good point. I think when you've got injury to the posterior aspect of the spine in the setting trauma or a fracture, and quite a heavy weighting. So I guess, you know, if you think about doing a laminectomy, moving the posterior elements, that's still, and everything else is intact, that'll be a 2, in which case you still manage conservatively in a setting of trauma. But really we know it doesn't destabilize on its own as an entity. But I think it's just due to the weighting that they've found that in the setting where there's more than likely going to be anterior trauma as well, that having the posterior aspect of things is got quite a heavy weighting.
Câu hỏi thứ hai của em là với cái
before I forget too, the DLC, the posterior component, certainly also involves the PLL. So it's like the second column. So you've sort of got 2 columns involved in that sense from the old classification.
Câu hỏi thứ hai là giáo sư có thể chia sẻ cái kinh nghiệm của bà với những trường hợp mà bệnh nhân TLIC 4 ạ. Với trường hợp nào bệnh nhân TLIC 4 thì giáo sư sẽ mổ, và trường hợp nào bệnh nhân TLIC 4 thì giáo sư sẽ điều trị và bảo tồn.
Okay, the second question about the TLIC 0.4. Well, I would like to ask about your experience about when you choose the surgery and when you choose non-operative treatment in the patient have the TLIC 4.
Oh, yes, it does vary. Yes.
Yeah.
And again, that's where it's your own surgical bias or, you know, your experience, etc. It depends on the patient. If the patient's old, you know, they're not going to do so well with surgery. You could try and manage conservatively. That's where there's that grey zone where there's no right or wrong answer. Usually the TLICs can be, you know, definite. They're going to be fine to be managed conservatively, or definite they need surgery. But there's just that buffer zone where it can be a little bit, you know, many ways to manage. Again, that is correct.
Can I make a comment and ask a question, and then I will give it back to Tanya? But these scores are largely written in Western countries, rich countries. I work in Africa quite a bit, and my experience is that almost all spinal fractures will heal and fuse. Girish is nodding because he works in India. Almost all spinal fractures will heal and fuse in young people if you vaguely immobilize them, and that these scores may not be appropriate for a resource-limited setting because you don't need to fuse or use expensive hardware in the majority of patients. So I'd be, well, Professor He is nodding, so he's the expert on Vietnam. So what I really want is for him to comment and say, are these scores that we use, because we have plenty of pedicle screws, are they appropriate always for so I'd like to know what Eric thinks, what Girish thinks. Are they appropriate for your setting? Because certainly where I work in Africa, I would not think of fusing someone with the sort of scores that we're talking about.
Yeah, thank you, Kate. Yes, for me, it's now in Vietnam. I don't know, it's, maybe in Australia, but in Vietnam, maybe the surgeons do too many fusions, too many. And even some case, some number, some thoracic or number disease, the surgeon do more surgery. And it is very easy to indicate surgery in Vietnam now. That I think it's wrong ways. And I can see some research when it is a randomization research, they they conduct a research about two groups. One group is numbers herniation disc treated by surgery, and another group treated by medical treatments. For the long-term result, the medical treatment is good result than surgery. And I think, and when I was a resident 30 years ago, we do very few surgery for spinal disease. My mother have a disc herniation disc, but never get surgery. Yeah, thank you very much. And I think for the young, you need to think about that. Like Kate talked about yesterday, we need to think about the quality of life of the patient first. Before you send them to make CT scan, MRI, or everything, or before to decide make surgery or not. Yes.
What a spinal fusion in India?
I totally agree with you. I'm afraid even there is simple lumbar disc surgeries are getting obsolete. Simple disc problems also end up getting fused. That is the quantum of instrumentation that is happening. Most of it, as was Dongli also said, unwanted surgeries happening. As far as spinal fusions for trauma are concerned, I agree with you. I would reserve them for incomplete cord injuries where you don't want to, the patient has got an incomplete cord injury. That is the case where you need to stabilize before some amount of mobilization is done. But it is randomly and rampantly done.
That's what we teach in Africa, that only if you have some preserved function and instability, that's the only absolute indication for fusion, and almost everything else will just heal on its own. Plaster jacket, collar, or just some rest.
Yes, I have some comments with about the spinal trauma in my country, in my hospital. We also use we also usually the classification, the IO spine and also the TLIP. But for some case, for the patient have the border between the conservative treatment and the surgical treatment. For example, the TLIP with the 4 score, we usually with the patient, and this depends on the patient. But sometimes some patient have, because when we discuss with them, they with the conservation treatment, we have to make the breast and rest the breast maybe to 4 to 6 months, 6 weeks, for example, and if we do the surgery with MIS for medical school physician, the benefits and maybe some communication for the surgery, and we also do for we depends on the choice of the patient. Yes.
Thank you. Thank you. And yes, the patient's choice is important, but it's also important that we give the evidence clearly.
Thank you. Yes, I agree entirely that there are far too many fusions performed. This is more though just to give the up and coming neurosurgeons an idea of the technology that's available and the way we're looking at things. We can improve quality of life. We do have access to simple things such as screws, because I find even patients who are really old and crumbly with osteoporosis, and they're not able to mobilize, it can change their lives if you just put some screws in with MIS. It's a very sort of relatively quick and safe procedure. It transforms their lives. But the key is to know which patients to operate on. I think I always preface any surgical operation with surgery as a last resort to the patients. And so they understand that really, you know, this is the process that we usually go. We go with conservative management, injections if we need be, or pain analgesia, etc. And then you just ask the patient, what would you like to do? Are you managing or not? I think, yes, you know, conservative management in countries that don't have this technology is certainly very appropriate to manage conservatively. But I think Vietnam particularly has the technology. It's going to be a lot more easily accessible, and it should be used if it's required so the patients are not suffering.
Yes, thank you for Professor for excellent presentation. I have two questions. The first question for Professor Phạm Anh Tuấn. I know the navigation is excellent for also both cranial and spinal surgery. And in your experience, which case you recommend use navigation, or you use for all of case, and which factors you decide to use navigation on spinal surgery? Thank you.
Yeah, in my knowledge and in my opinion, if you have if you had a 3D imaging and with the navigation system, you should do on the case with the spine surgery with the pedicle screw fixation. But some article have the suggestions recommend any benefits for the case with degenerative disease, lumbar disease, thoracic or lumbar disease with the deformity is the best. If you have the available the navigation system, you should do.